Good morning, everybody. I hope everyone's had a good morning so far. I want to thank the organizers for allowing me this opportunity to speak at this conference today. And I'm going to get started now. So I'm going to go off screen and then I'm going to share my screen with my slides. And then after I finish, we'll have a question and answer period and I'll come back on screen. All right, can everybody see the slide? Okay, great. All right, so what I'm going to talk to you about today is called non-motor symptoms in Parkinson's disease, focus on non-motor fluctuations. Sorry, I'm trying to move the cursor. I'm not sure why it's not moving. Hold on. Okay, hold on. For some reason, not advancing. I'm going to stop sharing for a second and try and redo it again. Give me 1 second. All right, apologies for that hiccup, I apologize. Okay, so just quickly to get through my disclosures, I received a grant and research support from the Parkinson Study Group and the Synovian Pharmaceuticals in relation to the non-motor fluctuation assessment instrument, which I'll talk more about shortly, as well as various honoraria and consulting fees for other pharmaceutical companies. So today I'm going to describe the clinical spectrum of non-motor symptoms and a subset of non-motor symptoms, non-motor fluctuations. I'm going to introduce and discuss the non-motor fluctuation assessment questionnaire, the NMOFA, which is the first validated instrument to capture and quantify non-motor fluctuations. The goal of this talk is to help you or your care partner identify non-motor fluctuations that may be present in your disease experience and become familiar with therapeutic strategies to address these. So I'm going to start this lecture with this picture of a historical essay. This is the cover of the original description of Parkinson's disease by Dr. James Parkinson in his 1817 essay on the shaking palsy. In it, he describes the now well-recognized features of Parkinson's disease, including tremors, stooped posture, gait impairment, and bradykinesia. Though Parkinson's disease has traditionally been thought of as a condition of affecting movement, Dr. Parkinson already then drew attention to some non-movement symptoms experienced by his patients, here specifically related to constipation. So this table provides a broad list of non-motor symptoms that people living with Parkinson's may experience. The table is categorized into neuropsychiatric, cognitive, autonomic, sensory, and sleep domains. Not every person experiences all these symptoms, but we recognize now that most people experience one or more non-motor symptoms, and the impact of non-motor symptoms may affect quality of life, maybe more adversely than motor symptoms. Static non-motor symptoms, meaning ones that don't fluctuate, are mediated by non-dopaminergic neurotransmitter systems, such as adrenergic, serotonergic, and cholinergic transmitter systems, and therefore don't typically respond to changes in medications like levodopa and other dopamine medications. So this table just confirms the assertion that I just made, meaning that non-motor symptoms are frequent. This paper was published earlier this year using the Movement Disorder Society Non-Motor Symptom Questionnaire to survey nearly 400 patients living with Parkinson's as to which non-motor symptom they experience and to determine the prevalence of those symptoms. In this study, they found that 99.7% of people with Parkinson's disease endorsed experiencing non-motor symptoms, so pretty much everybody. Non-motor fluctuations are an associated but distinct clinical phenomena from static non-motor symptoms, those that don't change, and occur in patients with Parkinson's disease who take levodopa. Now, this may be very confusing to patients and clinicians alike because a static and fluctuating non-motor symptom may be the same symptom, for example, anxiety, which may occur all the time, but may also, in addition, fluctuate in severity according to the timing of levodopa. However, the static versus the fluctuating symptoms may have different underlying pathophysiology, whereby fluctuations are dopaminergically mediated, and static symptoms, as I said, are mediated by other neurotransmitter systems. Even more confusing, both static and fluctuating symptoms may coexist in the same patient, and not surprisingly, patients, caregivers, and their physicians may have difficulty recognizing which symptoms are static and which fluctuate and when. But it's important to distinguish them, as treatment for static and fluctuating symptoms are different, with fluctuating symptoms responsive to optimization of dopaminergic medications. So this schematic, I don't know if this is used commonly in talks, so you may have seen this before. It serves to illustrate the concept of fluctuations in response to administration of levodopa. So you can see here that levodopa is taken at a certain time point, and then after 20 to 30 minutes, its effect kicks in and symptoms of Parkinson's may be alleviated, which may last for a period of time, and then wear off prior to the next dose. And you can see this kind of happens through the day in a fairly predictable fashion. Notably, there are problematic fluctuations that occur both in the on and in the off state, and some of these are listed here. And it's important to differentiate to know whether to reduce or to increase medications. Fluctuations have typically been associated with a motor response or motor fluctuation, so things like tremor getting better and worse depending on the timing of your medication, but there are also non-motor fluctuations that occur predictably depending on dopaminergic tone. So though as clinicians working with people living with Parkinson's, we anecdotally observe this phenomena frequently, the actual prevalence of non-motor fluctuations and impact of non-motor fluctuations on quality of life in the larger Parkinson's population is unknown, as up until recently, there's been no valid, reliable tool to capture and quantify these. So this study was performed back 20 years ago in 2002 while I was doing my fellowship at the Toronto Western Hospital with Dr. Tony Lang. And I presented this paper in Journal Club. And in it, 50 patients were surveyed regarding their experience of non-motor fluctuations. While the survey was not tested for its clinometric properties as to its validity or reliability, the results were still quite impressive, suggesting that there may be a large proportion of people that were impacted by non-motor fluctuations, and for some, it was very disabling. So I realized at that time that the lack of a method to reliably identify and quantify non-motor fluctuations due to an absence of a valid, reliable tool resulted in a major gap in our armamentarium of treating troublesome symptoms and targeting therapeutics to alleviate these. Without proper measuring tools to determine the true and precise prevalence of non-motor fluctuations and their impact on quality of life, it would be impossible to test novel treatments as to their impact on this set of troublesome symptoms. So in 2004, that's when I finished my fellowship and started my career in Philadelphia. I started working on what ultimately became the Non-Motor Fluctuation Assessment Questionnaire, what we came to call the NMOFA. To generate items for the NMOFA, we conducted nominal group technique sessions, which was a qualitative research methodology that brings together patients and their caregivers in small groups to generate items and then vote on their importance. In the spirit of the voice of the patient influencing research protocols, we wanted the questionnaire to reflect patient experience, and hence we chose this method of item generation. We had several groups, but once we reached saturation with these groups, meaning that the same items were being suggested now from new participants, we stopped conducting additional groups and we finalized a list of non-motor fluctuation items. We reviewed this list with some experts in the field to ensure that there weren't any other additional items that they identified. And we subsequently took this master list back to new patients for final endorsement. We also discussed language and formatting of the questionnaire in a focus group format before we finalized this initial questionnaire. And the table here on the right lists the 28 items we generated from this process. So nearly 17 years after starting the project and after 2 large-scale validation trials with a total of nearly 400 patients in both Canada and the US, we published the final validation paper in March of 2021. The NMOFA was officially endorsed and licensed by the International Parkinson and Movement Disorders Society, and it's currently in the process of being translated into other languages and also validated in those languages. The final 27-item self-administered NMOFA questionnaire is valid and reliable, capturing static and fluctuating non-motor symptoms in Parkinson's disease for use in clinical and research settings. And future studies, some of them already being conducted, will determine NMOFA's sensitivity to change and minimal clinically important difference. So this table from our paper demonstrates the prevalence of non-motor symptoms and non-motor fluctuation. And one of the features of this questionnaire, which is quite informative and unique, is that it surveys both static and fluctuating non-motor symptoms within an individual, such that a treating physician is able to differentiate between these symptoms and therefore customize treatments. This is especially relevant as some non-motor symptoms that are static are quite difficult to treat, for example, low energy and fatigue. Oftentimes when the symptom is static, there are no good solutions. However, while fatigue is the most frequent non-motor symptom endorsed, as seen in this table, it's also the non-motor symptom that fluctuates nearly half the time when it's present. This is relatively good news, as fatigue may improve if the fluctuations are reduced. So this is also true for some of these other difficult symptoms listed in this table, including cognitive symptoms, which typically would have limited options to treat. So now I'm going to further discuss non-motor fluctuations in the setting of a description of a case of a patient that I was caring for many years. And just to note that this patient and her family provided consent for me to share her journey as well as some pictures. So this was Mrs. S. When I saw her for the first time in 2014, she came to me with a chief complaint of, quote, "I feel bad all the time." And her Parkinson's story started 8 years earlier in 2006, when she experienced slowness and stiffness in her left arm. She had loss of sense of smell, we call that anosmia, and she had severe anxiety. A year later, she started to experience the typical left-hand resting tremor. She had difficulty walking, and in fact, she fell and broke her hip at the time. Her voice was soft and her face had minimal expression. And at that time, she was diagnosed with Parkinson's disease. Over the ensuing years, she had a really difficult time. She had had numerous falls. She had significant difficulty complying with the treatment regimens the doctors had given her. She became increasingly housebound and spent most of her time in bed. She felt short of breath all the time. She had severe anxiety, fatigue, and her family was really burdened mostly with her suffering. And because she was complaining of the shortness of breath and people didn't recognize what this was, she was being evaluated with invasive procedures to make sure that her heart and lungs were intact. And in fact, of course, nothing was found. The shortness of breath was not a manifestation of cardiac or pulmonary issues. So kind of to summarize what her problems were that first visit, they were pretty overwhelming. From a motor point of view, she had tremors. She had issues with mobility and bed mobility, meaning turning over in bed at night. Her toes were curling. She was having painful spasms in her feet. She had some swallowing problems and dyskinesia. These are involuntary movements. Additionally, she had a whole slew of non-motor symptoms, and these included nocturia, so frequent urination at night, severe constipation. She had bowel movements once a week. She experienced nausea, difficulty with sleep, including acting out her dreams, so REM behavior disorder, fatigue. She described hallucinations where she would hear symphonies in her head. She had cognitive impairment and difficulty understanding information. She was very anxious. As I said, she stated that she, quote, "can't breathe." She had palpitations, felt lightheaded and faint, another reason why she was scared to walk. And as a result of all this, she had poor hygiene and poor nutrition. And again, her family was quite overwhelmed. And so when I examined her that first time to try and correlate what her symptom complaints were and what we were able to find on examination, indeed, she had what's called orthostatic hypotension. So that means that when she had low blood pressure to begin with, but when she stood up, it dropped even further. And that's when she felt lightheaded. This can be a manifestation of Parkinson's disease itself through the autonomic nervous system, the involuntary nervous system, but that's augmented with many of the dopamine medications. In her case, she was also taking an antihypertensive, which made matters worse. Because she was in the clinic for so long, I saw her through a dose of medication. And in the off state, meaning when her medication wasn't working, she had a soft voice and her face was minimally expressive. Tremors were present. She was slow and her muscles were stiff. Her posture was stooped. She had poor balance. She was shuffling when she walked and her feet got stuck to the ground. And in fact, she became totally mute. She didn't say anything. And then when the medications kicked in, She had improvement in all her motor symptoms. She didn't have tremors. She wasn't slow or rigid. She didn't have freezing. And in fact, her whole demeanor changed. She was coherent. She was conversant, but she also had involuntary movements. So this was the medication she came to see me on, and this was a mess. There were a lot of medications here, taken very frequently, and she really had a hard time complying with this. Understandably, she didn't have a pill pack. She had these all in different pill containers, and she was importantly taking clonazepam, which is a sedative, many times during the day, which wasn't good. She was taking this antihypertensive as well. And antidepressant, Stalevo, is a combination of levodopa and Comtan. And so she was kind of having double doses of this. And it wasn't surprising that she wasn't doing well and that she wasn't able to comply with this. So what did we do? Well, it was very difficult to establish from her that first visit when she had the symptoms that she had, because she wasn't able to comply with the medication plan. And so it was impossible to really determine if there was any pattern to her symptoms, which is what we were trying to do to establish whether she had motor or non-motor fluctuations. So we started out, now, as you probably all know, things, Rome wasn't built in a day, so we couldn't really solve all the problems the first time we saw her, but we thought we would come up with a rational plan that then we could test our hypothesis to see, and then over time make further adjustments depending on her response to medication. So the initial plan was to consolidate her levodopa, such that instead of taking tablets every 2 hours, she would take them every 3 hours, taking 1.5 tablets 7 times a day. And this 3-hour interval still allowed her time to take the pills on an empty stomach and not overlap with protein. Now, she didn't know anything about that. I'm sure a lot of the audience members today are familiar with the issues related to protein and levodopa, as these are very important in optimization of symptom control. So protein interferes in the metabolism of levodopa, and you want to take your levodopa pills either half an hour before or 2 hours after a dose. And that interval, we think, should allow the stomach to be empty when taking levodopa medication, which is what is needed for optimal absorption and effective medication. So she was taking 1.5 pills every 3 hours. We were very aggressive about treating her constipation. And the reason that's important is similar in that when you're constipated, everything is backed up. So in fact, your stomach isn't emptying as you think it would be. In Parkinson's, there's always delayed gastric emptying and constipation as a result of this autonomic dysfunction, the involuntary nervous system, which is also involved in Parkinson's disease. So people get nervous in saying, well, I don't want to get hooked on laxatives, but the truth is in Parkinson's, that is nothing to worry about. It's more important to avoid constipation. In that first setting, we actually had her get completely cleaned out with a colonic prep to make sure that she was totally cleaned out, and then put her on a very aggressive regimen of diet and Restoralax and other agents to ensure that she had a full evacuation every day. We asked her family doctor to reduce the antihypertensive medication, and we also aggressively repleted her salt and fluids. So she was fluid restricting because she had to urinate all the time, so she didn't really want to drink, but she ultimately became dehydrated. So we wanted to address the orthostatic hypotension. For the hallucinations, we added a small dose of Seroquel, which also helped her sleep at night. And most important, we gave her a motor diary and explained what to do with it. So a motor diary is just a term that we use to have people record what time they take their pills, what time they eat, what they're eating, what time they have their symptoms, meaning tremors, and in her case, the shortness of breath and so forth. And alternately, what time do they have the dyskinesia? So to try and understand the pattern of on and off. Additionally, we referred her to our colleagues in psychiatry to help manage the anxiety and taper the clonazepam, because this sedative, particularly even if it has short-term benefit in managing some anxiety, It can increase falls. It can cause confusion. It's really a medication we want to use as little of as possible. We referred her to an expert in urology, an expert in terms of the Parkinson's related issues, urological issues. She was referred for a cognitive assessment. We started melatonin at night for her sleep reenactment behavior. We taught her about sleep hygiene because of all her symptoms. She would be up all night and sleeping during the day, which wasn't ideal. We put her medications in a blister pack, and we had her meet with our interdisciplinary team, including speech therapist, occupational therapist, to help with strategies in the home, like mobility in the bed, reducing fall risks in the home if there's any loose carpets or things like that. Physical therapist to start her on an exercise program and monitor her safety when walking, a pharmacist to help manage the medications, a dietitian to discuss all these issues related to protein and levodopa and constipation and ensure her healthy diet. And additionally, we helped them obtain PSW support for some respite for her family. And we had her come back after 2 weeks with the diary. And it became quite clear what her pattern, she had a very clear pattern in terms of the response to medication. She had excellent on time for a period of 2 hours out of the 3 of every dose. And when she was on again, her tremors improved, her mood improved. She didn't have any shortness of breath. But when her medication was off in that last hour, she had tremors, slowness. She couldn't walk. She felt she was stiff. Her toes were curling. And she also had nausea, crippling anxiety, shortness of breath, palpitations, the urinary urgency, and that's when she was bedbound. So it was very important for us to be able to differentiate that it wasn't that she was feeling bad, quote, all the time. She was feeling bad when her medications weren't working. And these symptoms weren't just tremors and things that you could see, but also in all her internal sensations of nausea and anxiety and so forth. So then we were challenged with, well, what are we going to do to reduce these off symptoms without increasing side effects? Because as you all know, for everything we do, there's a cost. By increasing medications, just increasing the dose of levodopa, we put her at risk for increased hallucinations as well as more dyskinesia and further drop in her blood pressure. Dopamine agonists, things like Nupro, Mirapex, these are all medications that again, have a significant side effect profile. In this lady, were not appropriate. They increase hallucinations, drop blood pressures, cause nausea. I say that, but that's just in this specific situation. They can be excellent interventions under the right circumstances for the right people. So it's important that the statements I'm making are seen in context. I'm talking specifically regarding her specific situation, given that she already was having these problems like orthostatic hypotension and hallucinations and cognitive impairment. We didn't want to add Azilect, an MAOB inhibitor, which also increases the life of the levodopa because she was taking an SSRI. And even though it's actually pretty safe to use these two drugs together, sometimes pharmacists are concerned that there can be interactions between these two drugs, and we tend not to use them together. So what did we do? Well, we used a little known strategy that I learned in my days of fellowship with Dr. Tony Lang, and this is kind of a clinical pearl. When you've sort of gotten to the end of the road with using oral treatments and you're kind of stuck between a rock and a hard place between the effects of the disease versus the side effects of the medications. We didn't want to increase her overall daily dose of levodopa. So what we did is we took the total amount that she took in a day and we knew that she lasted for only 2 hours. So again, we did decide that she would get treated every 2 hours in this specific circumstance. But we wanted to, as I said, keep the doses low, and we didn't want to increase them. Now, levodopa comes as a pill. So if you cut it in half, you can have 50 milligrams or you can have 100 milligrams, but you can't have more precise than either 50 milligrams or 100 milligrams. And in this case, when we divided the 1,050 milligrams by 8 doses, which was every 2 hours, we came up with approximately 135 milligrams. Now, in order to do this, we had to make the liquid, liquid levodopa in order to be more precise. And we put her on what's called a protein redistribution diet. So we recognize that if people are taking pills every 2 hours, they can't still have a time when they're not eating protein. So the idea is that you don't eat protein throughout the day. And then at night, you have a much larger protein meal to make up for what you didn't eat during the day. And we recognize that there's still a trade-off here, that at night you may not have as good control of symptoms, but most people are more sedentary in the evening and they're willing to make that sacrifice in order to have better function during the day. And again, ongoing constipation and hypotension management. And so I just wanted to give a little bit of background about this liquid levodopa, just to clarify how it works. There actually isn't a whole lot of study about this, but one study was done back in 1998 that looked to see why was this effective. So they did two parts of the study. The first part was to compare absorption of levodopa in tablet form and liquid form. So they had 9 patients, and this is what's called a crossover design. So all the patients had both types of levodopa. The first time they took 1 tablet of levodopa with a glass of water. And the second time they took it, it was a glass of water dissolved with the levodopa. And each time they had the peak concentration of the dopamine measured in their blood, and also the time to reach that peak concentration. And what they found was that there was actually no difference in peak concentration or time to reach the peak concentration between the tablet or liquid formulation. So it's not that by taking it in a liquid form, do you absorb it better, or does it work faster? That's not what happens. In fact, the second part of the study was taking patients with severe motor fluctuations. Now, this was back in 1998, so people didn't know about non-motor fluctuations. So they looked at people with severe motor fluctuations. And they did the same thing. They fractionated the levodopa that they were taking. So they took on average 950 milligrams per day, and they fractionated that to take every hour at a concentration of 1 gram per liter. And then they measured what's called the UPDRS-4, and this is complications of levodopa. So things like dyskinesia and off periods. And they scored them after 5 months of being on liquid levodopa, taking it every hour. And 7 out of 10 improved subjectively, and even objectively in terms of looking at the numbers in the UPDRS-4, there was a reduction in the complications. So these patients decided to stay on this treatment long term. And the conclusion of the paper was, and I think that this is what we believe, is that the ability to easily fractionate the dose and thereby administer small, frequent doses customized for individual patients is the most likely explanation for improved symptom control. So for our patient, indeed, she had an excellent benefit. She had substantially reduced off periods. This translated into being able to go grocery shopping, to cooking, cleaning the house, attending church. Her hallucinations improved markedly when we introduced rivastigmine, and this is a cognitive enhancing agent, but for people with Parkinson's, it actually is a first-line agent to manage hallucinations. And we tapered the Seroquel, which was a neuroleptic, which is an antipsychotic drug, which we didn't really want to use. For her nighttime sleep, we referred her, urination, we referred her to the Parkinson's urologist, and he provided her with medication, which improved this. Her constipation was resolved. She was eating a healthy protein redistributed diet. Her blood pressure increased. She exercised regularly. She had PSW support. Her sleep improved. She had less fatigue. So she was doing really well. She was really happy. But as we all know, Parkinson's never stays the same. And she'd already experienced disease for a prolonged period of time. This was now about, I think, 2016 or so. So she'd had symptoms for 10 years. And she started to experience some difficult symptoms that we know occur as the disease advances. And this is called failure of on or delayed on. Failure of on is when you take medication, but they don't kick in. Delayed on is when you take medication, but it takes an hour or longer for them to kick in. Unpredictable off, which is all of a sudden the medications just stop working, even in the middle of an on cycle, and the symptoms recur. So the reason that this happened, again, going back to this whole protein levodopa business, that's the main issue that happens with time. It becomes more and more prominent. So the delayed gastric emptying gets worse, and there's increased protein levodopa interactions, and the fact that constipation is often a problem that contributes to this as well. So what do we do now? So now we talk about advanced treatments. So this lady was 80 years old, a person that has good response to levodopa, but has side effects or these kind of complications like delayed on or sudden unpredictable offs. They are often good candidates for the advanced therapies that we can offer. One of them is deep brain stimulation. But in this case, she was already 80 years old, and most patients that are taken for deep brain stimulation are younger, 70 or younger. Sometimes they take a few years older, but it all depends on their circumstances. She had cognitive impairment, so that's typically when that is present, deep brain stimulation is not offered. But there's another excellent treatment that we were able to offer her, and she did very well with this. And this is called Duodopa, and this is levodopa carbidopa intestinal gel. And what this is now, it's still requires some invasive procedures. So it requires an outpatient gastroenterology procedure where a tube is inserted into the stomach. As you can see here, there is sort of this little button here. So on the outside, you see this outer portion that's attached to the pump, which supports a cartridge full of levodopa, concentrated gel of levodopa, which is replaced every day. And then this tube goes through the stomach and then through the small intestine and then empties into here. So this is where the levodopa comes out. So it bypasses basically the stomach and all this business with protein and levodopa. So she underwent this procedure, and then it requires some titration. And we start with a morning dose because it's usually given for 16 hours, though sometimes under certain circumstances, it can be given for 24 hours. But in this case, it was given for 16 hours. So she got sort of a boost in the morning. And then she had a continuous rate, receiving it constantly. And then she had some extra doses if she needed for the day if she was feeling low. And she also, because she didn't get it at night, she took some tablets at night. And with this, she really had a really excellent response. As you can see here in these pictures, she was quite a character. She really liked fashion, and she liked to go to the casino with her husband. And this was her granddaughter that she enjoyed. And I'm just going to show you a video now of her with her granddaughter. High five, Zoe. Hi, Zoe. Sorry. So as you can see, that it's hard to reconcile that video of her with that first visit that we had. So in summary, non-motor symptoms can fluctuate similar to motor symptoms and may result in substantial disability and reduction in quality of life. Common non-motor fluctuations include cognitive difficulties, mood issues, pain, and fatigue. Non-motor fluctuations can be captured and quantified using the NMOFA, a validated questionnaire that helps the clinician identify non-motor symptoms that are treatable with optimizing dopaminergic strategies. And treatment of non-motor fluctuations is tailored to the individual and depends on their risk profile of symptoms and side effects. And that brings me to the end of the formal part of this talk. And I'm going to stop sharing my screen to answer any questions. All right. Can you see me now? Yep. Is that good? Okay. So if anybody has any questions, I'm not sure how you guys want to do this. If somebody wants to read it out or stand up and ask a question.
Yeah, we have some mics in the audience, so we'll just ask if anyone has a question for Dr. Kleiner.
Dr. Kleiner, can you hear me?
I can hear you now.
Oh, okay, great. All right. Take two.
Okay.
I'm Catherine Smart. I'm with an organization called Living Better with Parkinson's, based out of South Georgian Bay. We're a grassroots organization that we started just over a year ago to provide support to people living with Parkinson's and their caregivers and their family members and the medical professionals. So I
That's
was really,
wonderful.
yeah, thank you. And so I was really intrigued by the journey that you took us on with regard to the woman that received such extraordinary care. One of the comments that I get regularly is, where do I start? Who do I go to? What are the resources? Small town Ontario, there's a
Yeah.
number of GPs who, well, especially now with COVID, everyone's stretched. But it's more so from my perspective as the part-time executive director of this organization, how do I best serve? What kind of resources can I provide to, increase confidence and to, put a person on the right track?
And that's an absolutely excellent question. And your question is a systemic problem, a systemic issue, is how do we get information to people to empower themselves so that they can advocate for themselves and that they can be part of the team to make decisions and customize the treatments they need, because every person is completely different priorities, different symptoms, different constellation of circumstances. And that is really why we started the initiative of the website, which is Live Well with Parkinson's, for exactly this reason. I had this actually, it was Parkinson Society of Canada, where we had this sort of meet the doctor session back in 2008. And all these people came around and asked me all these questions. And I said, oh my God, how do they not know this? If only they knew this, their lives would be so much better. And so there's really a gap in this kind of information. And then we sort of thought, how do we scale this so that every person has access to this, even if they live in remote communities, even if they don't have access to a specialist? And so we put together this website, the Live Well with Parkinson's website, which I think is fairly informative. It's still available. That being said, I'm a doctor. I'm not a website designer. And so there are some improvements to be made. And we're currently in the process. We've just submitted a grant, in fact, to the Parkinson Society of Canada to help us revamp this website to ensure that the information that we have there really reaches people in a way that they can understand it. And so we're working with a team across Ontario, so people from the Toronto Western, as well as from Ryerson University and from the Ontario College of Art and Design, to revamp and then test with patients, the end user, to ensure that the materials that we are developing are really beneficial to them and that they can actually implement the recommendations and make changes such that they have an improvement in their own management of symptoms. And so the focus of this particular study of this, the way we're going to do this is we're actually focusing on the whole protein levodopa information that people need to have and really understand, because it's really complicated. And then also wearing off, understanding the wearing off. So these are the two sort of high yield subjects that we're starting with. And we're hoping that we can continue to add to this website, and that this website will be, on the Parkinson, it's already on the Parkinson Society of Canada website, but really continue to add information to this. That being said, I would strongly encourage any person living with Parkinson's to try and get a referral to a movement disorder center, even if now through COVID, for better or for worse, telehealth has become standard of care. And so, most of us are seeing people, especially if they're remote, through virtual care. So we can provide this kind of at least an initial assessment, initial recommendations, identifying the problems early on. I can't reinforce enough how important exercise is. And early on, not just, at later stages, but early on. Right now, we don't yet have a cure for Parkinson's. We don't even have a pharmaceutical that will delay or prevent progression. But the research shows that exercise and aerobic exercise, so vigorous exercise where you get your heart rate up, actually has an impact on longevity and on reduction in progression and maintaining mobility and overall general well-being. So sometimes when I see patients for the first time and they're doing quite well, I say, listen to me, exercise like your life depends on it, because your life depends on it. And I've had many people come back to me years later saying, I took your advice and I started a vigorous exercise program and it changed my life. And so that's, there's a lot of common sense here. Live well, sleep at night. That's important. Eat properly, engage with your family, stay and involved in your community, doing the things that you like to do, and be alert to your symptoms. It's really, really important to understand the pattern of your symptoms as it relates to medications, and being able to report that to your doctor, because then your doctor is in a better place to be able to make adjustments. So as I said, the first time when we saw that lady, I was a little overwhelmed when she says everything is horrible all the time. And then we found out, in fact, not everything is horrible and it's not all the time. And there are things that to be done. And I think that is really important. But I agree that there's a general lack of awareness, knowledge, healthcare resources, time, access to specialized care, access to multidisciplinary care. All that stuff is really, really requires improvements in our healthcare system. But there's a lot an individual can do, and a person that gets empowered can really live a better life.
Thank you, Dr. Kleiner. We have another question.
Yeah, it's David Brown here. And I've had a problem with the anxiety and the depression, and the depression has been horrible. Last year I started on a mood-altering drug, and it's helped tremendously with my sleeping. Constipation is a real problem. The problem with the getting up and exercising is I don't have much energy to do that, it seems.
Yeah.
And it just feels like I'm on a vicious circle all the time. My wife is going crazy with me, trying to get me to do stuff. And I don't have the energy to do it anymore. Yeah. I used to be very active. I exercised every day in the gym and stuff, up until about 4 years ago, and then I was diagnosed, and it was a gradual thing. It was going downhill for a long time. When I finally got diagnosed, I was well into it, it seemed. I've retired at that point. I had no choice. My other problem is that I don't think very well, very clearly most of the time. I seem to have almost all of those things that you had up on the list. My question is, I'm going to see Dr. Stewart here in Cambridge, a motion specialist. He's the first time I've been able to see a motion specialist since all this started. And I'm wondering if I can get that sheet. Would it be helpful to answer all those questions before I go to see him?
I have it.
Well, are you talking about the non-motor fluctuation questionnaire?
Yeah.
I already found it.
Oh,
I think that probably would be helpful to him. Absolutely. Yep. It's available online. I believe, I think it is available online. I'm happy to send it to the organizers if they want to, if it isn't, and they can distribute it to their readership.
That would be great. Thank you, Dr. Kleiner.
Yeah, my pleasure.
Another question over here.
We're over here. Oh, there we go.
Hi, it's Ruth Weber. I wondered, how does one qualify for the pump? And is that pump useful for motor, not non-motor, but motor symptoms?
Oh, absolutely. In fact, currently the indication is only for motor symptoms. So, we're in the process of doing a study right now, looking at non-motor fluctuations using our instrument for people that have had the pump as well as deep brain stimulation, and seeing what impact, what we can capture. We know anecdotally that the pump works for both motor and non-motor symptoms, non-motor fluctuations, for the exact reasons that we that were described in the lecture. So no question that it's definitely very effective for the motor symptoms. You would need to be referred to a specialized center that does this, because it's not available to the general neurologist. But we'd be more than happy to see you if you're interested at our clinic at Baycrest. Toronto Western Hospital does this as well. There's a center in London. I think there's a center in Hamilton. I think Kingston as well. Ottawa. So, in all the major cities, there are centers that do ADOPA, and it's a very effective treatment.
That's
What I
wonderful.
Yeah, what I usually do when I'm referred patients for duodopa is I first try and see if I can optimize the medications further, because oftentimes there are still little tricks that we can do. And I've had patients that have been referred to me for the duodopa, and then we deferred it for a good 3 or 4 years with further optimization of oral medications. So Parkinson's drug treatment is more art than science, or maybe it's art and science. But until I've been convinced that we've done every permutation and combination of the oral medications, I generally don't move forward with the duodopa. Again, it's a personal decision. Some people say, I want to put it off as long as possible, and other people say, you know what, I don't need this headache of taking medications every 2 hours. There's no right answer. The right answer is what's right for you, but it does require a dedicated specialist to be able to implement the treatment.
Thank you so much, Dr. Kleiner. I'm afraid we have to stop with the questions now, but we certainly appreciate you sharing your expertise and knowledge, and the case study that you shared with us was very inspiring.
My pleasure. Thank you for the opportunity.
Mhm.